Patients that present with knee arthritis typically have, for the most part, pain, which is primarily located to the knee itself. Because of the anatomy of the knee, typically the arthritis is located predominantly on one side or the other, either the medial or lateral side, and they will have most of their symptoms in this area as well. Typically they can also have some pain anteriorly, either from the patellofemoral joint arthritis that may be present, or from weakness of the quadriceps and difficulty with walking because of flexion contractures. Patients with knee arthritis also have difficulties with activities of daily living. Next we'll move on to the knee exam. The first thing that I will do in examining a patient's knee is to check the coronal plane alignment. I will have the patient lie on the table and assess the mechanical axis of the extremity, either looking for a valgus deformity at the knees, which would be a knock-knee deformity, or a varus deformity at the knees, which would be more of a bow-legged deformity. Our patient here today has normal mechanical axis in both knees. I then will check for an effusion, and there are two ways to do this. If they have a large effusion, it is relatively easy to identify. I will take my hand and sweep any fluid from the suprapatellar pouch, which is above the patella, down into the knee joint itself, then place my thumb up over the patella and check to see if it is floating on a layer of fluid. That will, if it floats, you will feel it sink down and then contact the trochlea of the femur, which will tell you that there is an effusion in the knee. For patients that have a smaller effusion or a more subtle finding, what I will do is I will sweep the fluid out of the suprapatellar pouch from one side of the knee, and then I will compress the other side of the knee to try and elicit a fluid wave that comes across in the soft spot here. The next thing that I will assess is the flexion and extension of the knee. I will first check for a flexion contracture, and my first test for doing that is to grab both of the ankles, place my thumbs on the medial malleoli, and I will lift the legs off the table, and I will place my thumbs next to each other so that I know that the ankles are in the same position. I will then look at the knees to see if they are both in the same position as well. If there is a flexion contracture on one side, then that patella will be higher than the contralateral extremity. Another way to assess this is to leave the patient, let the patient keep their leg on the bed, and to slide your hand in the popliteal area between the table and the knee. Your hand should slide through easily, but will brush against the popliteal space of the patient. If it does not, then there is typically a flexion contracture present. I will then check flexion of the knee, have the patient bend the knee as far as it will go. In a normal knee, this is typically up to 135 degrees. In an arthritic patient, this is typically much less, sometimes less than 90. Next, I will assess stability in the knee, looking at examining the medial collateral ligament, the lateral collateral ligament, and the cruciate ligaments. In an arthritic knee, as I mentioned before, typically there is a varus or valgus deformity, and it is important to assess whether that deformity is correctable or is uncorrectable. To assess the collateral ligaments, I will typically let the knee flex approximately 15 degrees. In testing the medial collateral ligament, I will grab the ankle. With the hand closest to it, I will place my other hand on the lateral side of the knee and try to open the medial side of the knee. In assessing the lateral collateral ligament, I will do just the opposite, placing my hand on the medial side of the knee and then apply a varus stress. Flexing the knee to approximately 15 degrees is the most sensitive test for the collateral ligaments, rather than having the knee in full extension, as in this position the posterior capsule can become tight and make the knee seem stable when in fact the collateral ligaments are loose. To test the cruciate ligaments, I will typically do a Lockman exam or a drawer exam. With the Lockman exam, again the knee is flexed approximately 15 degrees. I will grab the thigh with one hand, the calf with the other, and try to slide or translate the tibia both anteriorly and posteriorly. There should be a couple millimeters of play in either direction, but nothing more than that, and the end point should feel quite firm. This is a test that is quite difficult and requires practice to assess it appropriately. To do a drawer exam, I'll flex the knee to 90 degrees, and then I would typically sit on the table to prevent the patient's foot from moving. I will then, to do the anterior drawer, would place my hand behind the calf and pull forward. And if the ACL is deficient or loose, the tibia will sublux anteriorly. To do a posterior drawer, I will apply pressure posteriorly to assess the posterior cruciate ligament. I will next assess tenderness of the knee. The first thing that I will do is check the joint lines, and I find that it's easier to identify them with the knee in the flexed position. The medial joint line can be felt between the femur here and the tibia here. It is a soft spot in between the two, and I will assess for tenderness all the way posteriorly as well as anteriorly. The lateral joint line can be found in a similar way, again between the bony landmarks of the femur here, the tibia here, and there's a soft spot in between. And I will assess again around the entire perimeter of the joint. Other areas that I will assess for tenderness around the knee include Gerdy's tubercle, which is a prominence just lateral to the tibial tubercle where the iliotibial band inserts. Patients can have tendinitis of the iliotibial band, or they can develop a friction syndrome, and they will have tenderness here as well as along the path of the iliotibial band proximal to this as it goes up to the hip. On the medial side of the knee, the pes anserine bursa and tendons are located just over the medial tibial plateau, and these can become inflamed and painful as well. And then finally, the patellofemoral joint can be assessed by applying direct pressure to the patella or to slide the patella back and forth in its groove to assess for discomfort there. I find it very important to assess gait in assessing the hip and knee, especially in the arthritic patient. Typically, with normal gait, you should have a symmetric gait pattern, similar stance phase on both feet, both right and left foot. A patient that has an antalgic gait or painful gait will have a shortened stance phase on the involved extremity. So here my stance phase on my right foot is shorter than on my left, and that denotes that I am having pain there and difficulty walking. A coxalgic gait pattern or a painful hip pattern not only has a shortened stance phase, but you also will see some trunk lean to help decrease the forces across the hip. So in a coxalgic gait, not only will the stance phase be shortened, but the trunk will lean to the involved side to relieve the pressure on the painful hip. And finally, there is the Trendelenburg gait, which is from a weakness of the hip abductors. This is not a painful gait, and the stance phases on each extremity are the same. But because of the weakness, there is some trunk roll. There are two types of Trendelenburg gait. There is a compensated Trendelenburg gait and the non-compensated gait. In the non-compensated gait, the body will fall away from the involved hip because the abductors are unable to keep the pelvis square. In the compensated gait, the patient will actually lean over the involved side to try to balance the forces and make the